Here is your question. Okay, so if you have read and understood, considering it critical care scenario, please tell me how would you manage this patient now?
Okay. Is a patient according to critical surgical patient?
Yes,
I will ensure secure the airway and check for auscultate the lungs and put the patient in pulse oximetry for the saturation, and also then I go for the circulation. The patient have I will check the chart of the patient. Um, give him another dose of painkiller and give the patient fluid and check the vital signs of the patient. Uh, After that, uh, uh, I will examine the patient to look the cause, why we have
just hold
respiratory depression.
this patient, just like STEM says, patient is
Mm-hmm.
undergoing respiratory depression. If you'll
Mm-hmm.
take the arterial blood gas at this moment, what do you
Mm-hmm.
expect to see?
Respect to see pH low and CO2 high and CO3 normal, like respiratory acidosis.
Very good. So
Mm,
in case of respiratory acidosis, you already know that patient has already been given only morphine. So, right, considering, or you can tell me yourself, when would you judge that patient can be, or maybe is undergoing opioid toxicity or has been given morphine overdose?
Okay, I will first check the chart of the patient, how many take, how many doses of morphine, and check the general look and the vital. The patient will be like gasping to breathe and use have shallow breathing and using the accessory muscles. Maybe drowsy, confused, or have meiosis in the eyes, and all the sign of toxicity. Maybe I
Okay.
found it.
What is the antidote of morphine that you will give?
I will give
Naloxone.
naloxone, yeah,
Okay.
naloxone, every 3 minutes, like 0.5 to till 2 milligram.
All right.
Uh,
Can you please explain, in case of respiratory acidosis, what is the mechanism behind in which carbon dioxide retention occurs rather than expulsion out of the body?
okay, because morphine was the opioid working in the more receptor in the medulla oblongata in the brainstem, the same area of the respiratory center. So we'll block the respiratory center if it is offered, if it is toxic dose that lead to the body cannot respond to hypercapnia.
Yes.
The respiratory center cannot respond to increase the breathing after this hypercapnia. So that lead to respiratory depression and decrease the movement of the respiratory muscles and lead to the accumulation of the CO2 retention in the lung.
Okay. This patient will be managed where? I mean, who
Should
would
we
you
manage it
involve? Yes.
in ITU
Yes.
because patient will need to mechanical ventilator at the moment to support the breathing.
Good.
And also to monitoring the naloxone. Also will involve these anesthesia doctors and also anesthesia and intensive care doctor and pain management team, and also toxicological, if there is toxicology unit in the hospital, or poisoning team. Also I will involve it with the surgeon who do the operation.
Okay, can you please tell me how kidneys would react to regulate this acid-base disbalance which has occurred in the body?
Okay, the kidney will do as a compensatory mechanism, reabsorb or prevent excretion of bicarbonate, try to compensate this acidosis to increase the alkalinicity of the blood.
Yes.
Also, yeah, also this is what the kidney do.
How they excrete acid?
Yeah, also
in the form of?
the acid will add hydrogen will
yes, good.
yeah, excrete it.
Right. Can you please tell me what is chloride shift?
Chloride shift, it is a normal buffer of the cell in the body. Inside the RBCs, we'll have shifting of the chloride to inside the cells, and shifting the bicarbonate outside the cells to maintaining the natural electricity of the cells.
Good. Can you explain to me why a partial pressure of oxygen would remain in the normal range and there'll be no sign of metabolic compensation?
Because the kidney take time to respond.
Yes.
For this respiratory acidosis, like
yes.
take 2 to 3 days.
Yes.
And also patient on high oxygen or in the ventilator will not appear the PaO to different.
How many types of respiratory failure are you aware of?
Okay, we have type 1 respiratory failure. It is like hypoxic type. And we have type 2 respiratory failure, usually as in chronic disease. And in this case of drug toxicity, like hypercapnic cause.
Okay, so other than this condition, what are the other conditions that can lead to type 2 respiratory failure? Can you give some examples?
Like chronic obstructive pulmonary disease,
very good.
asthma.
Asthma, COPD, very nice, excellent.
Yeah.
Even chronic bronchitis.
Yeah,
chronic bronchitis. All right, okay. Can you please tell me, you've already told me every question, very good. Right, how should or what should be the response of the body as a result of hypercarbia?
Of what, please, again?
Hypercarbia, increased
okay, the body as normal, as a compensatory as the normal will be increase the depth and rate of the respiration to hyperventilation.
Which receptors are stimulated because of that?
Okay, first we have the peripheral receptor and the chemoreceptor in the carotid body and the aortic arch will respond to the first response. Then central chemoreceptor in the medulla.
Yes.
That responds to CO2 in the blood across the blood-brain barrier. So that will lead to sending stimulus to the lung to increase the rate and depth of respiration, lead to hyperventilation to wash off CO2. But in our patient, we cannot do because the depression of the respiratory
Very good. Okay. Excellent. Thank you.
Okay. Thank you, Mom.